Hi everyone! Welcome to Medicine for Dummies. I'm Dr. V. As you know, I talk about all kinds of different diseases and conditions for medical and nursing students. These are specifically targeted for the university curriculum and exam-oriented. Today, we will be starting another new topic, pyrexia of unknown origin. We will be going into detail on one of the causes for PUO, which is juvenile idiopathic arthritis, specifically in another video. And even though they can be watched separately, for better understanding, I recommend watching both back to back. Of course, don't forget to like, subscribe, and share, and comment below if you want any other topics covered. So, we begin the topic pyrexia of unknown origin. Basically, what it means is that there is a fever without an origin. The elementary definition is that there is usually fever for more than 3 weeks or 21 days, and despite adequate primary investigation, a cause is not found. The exact definition changes from time to time and depending on the body issuing the definition, so it is better to refer a textbook that you use. In this video, we will be going into great detail on the history, examination, and investigations. Note that we will not be talking about a specific condition in this video, as the basis of this case is that there is no proper diagnosis. So, let's begin. If you have watched the video on acute gastroenteritis, I described the way to take a thorough history. A more detailed video will be coming soon. We start the history off with the presenting complaint. So whatever the mother of the child tells you as the main problem will be the presenting complaint. It could be something like having fever for 2 months or something like having enlarged neck masses suggestive of lymphadenopathy. This should be stated clearly, succinctly, and should not be described in great detail. Then we start off the history of the presenting complaint. First, the fever has to be described. That is, what kind of fever was it, what was the highest fever, were there fever-free periods, and the like. This should be described in detail so that a very thorough idea can be gained because different diseases have different types of features to the fever. After that, the chronology of events should be described. It is easier for you to create a timeline for this, like you can see here in the video. It should be told to the examiner as a story on how the fever changed and how the symptoms progressed. Also, all tests done and all treatments given and their response should be mentioned as far as the mother knows. Once you have described the fever and its associated symptoms, you should exclude the differential diagnoses. Note that there are hundreds of causes for pyrexia of an unknown origin. Here, I will be talking about only the most common ones you encounter in day-to-day practice, or ones that can be detrimental if not diagnosed. So, first off, tuberculosis is common in most developing nations, and these children present with chronic cough, loss of appetite, loss of weight, and night sweats. You can ask for these symptoms in your history to exclude TB. Especially in young females, connective tissue disorders like SLE are common. You can ask for oral ulcers, hair loss, and a photosensitive butterfly-shaped rash on the cheeks. JIA, or juvenile idiopathic arthritis, is also a cause for PUO, and you can ask for swollen joints and a salmon pink rash that is quite typical for the disease, but can be hard to see as it occurs at the peak of fever and disappears quite fast. The mother may have noticed this, and you can clarify this through her. Other causes are osteomyelitis, which can present with bone pain and discharging sinuses, typically around the knee joint and the shin. Even though malaria has been eradicated or eliminated in many countries, you can still get this mosquito-borne illness when traveling to endemic countries, so ask for recent travel history. Chronic hepatitis, especially with hepatitis B and C, can cause a prolonged fever, and they might have yellowish discoloration of eyes due to bilirubin accumulation or right hypochondriac pain. Bone tumors, which may be visible as a bony swelling around the knee joint, can also cause prolonged fevers. Solid organ malignancies, meaning malignancies in organs like the liver and kidney, usually present with constitutional symptoms like loss of weight and loss of appetite. Other features can be organ-specific, like in renal tumors you can get hematuria. Hematological malignancies also cause PUO, and acute lymphoblastic leukemia is a common childhood tumor. These patients get lymphadenopathy, recurrent infections, and petechiae because of associated thrombocytopenia. Cat scratch disease is another interesting condition. You get infected by Bartonella species after a recent bite or scratch from a pet, and you get a regional lymphadenitis. You can inquire about these in your history. Toxoplasmosis is again a condition that is associated with pets and handling feces of pets or eating undercooked meat. It's a parasitic infection you can get, and although not that common, it is still an important diagnosis to exclude. Others, like hyperthyroidism, is sometimes forgotten because it is not an infection. But due to the increased metabolism seen in thyrotoxic patients, they can be warm and there may be associated diarrhea, sweating, increased appetite, and loss of weight. Brucellosis is an interesting condition which is spread by Brucella species and is usually seen in children where there is cow farming. It can be acquired by eating undercooked beef or by drinking contaminated milk. Melioidosis is a condition where you get multiple abscesses in many organs like breast abscesses and liver abscesses. You can ask for high swinging fever and skin lesions suggestive of pustules. Unfortunately, in some children, especially teenagers, you can get STDs and HIV either through sexual abuse or unprotected sexual contact, so it is important to ask about these things with due sensitivity and privacy. Lastly, infective endocarditis is a very important cause of PUO, and you can ask about a history of dental caries and congenital heart disease. As I have said before in my previous videos, a history should be focused on coming to a diagnosis, assessing risk factors for the most likely diagnosis, and look for complications. So we can ask for risk factors according to the most likely diagnosis if you arrived at one, when excluding differential diagnoses. This is also a good place to ask about the travel history, contact history, sexual history, hygiene, and environment, as a lot of these things can give a clue to the source of the infection or condition. Next, we must go on to the complications, and this is again according to the most likely diagnosis. Other kind of common complications of most of these diagnoses are growth failure and features of micronutrient deficiencies. After that, you can finish off the history of the presenting complaint by describing what happened after admission up to now and how it has affected the child's daily activities. Then finish off the history with the other parts like birth, growth, and development history. So this is mainly important in children less than 5 years. In older children, development may not be that important as many of the milestones have been reached. Ask about allergic history, past medical and surgical history, and dietary history. In family history, you can ask about any family members with connective tissue disorders, hematological disorders or malignancies, and endocrine disorders. And with a detailed social history on the environment, schooling, and relationship with parents and siblings. Once a thorough history has been obtained, move on to the examination. Just like the history, the examination should be very detailed because we are looking for any features of any condition that may have been missed previously. So, as always, the examination should begin with the height, weight, and BMI and plotting on graphs. If the patient has a fever, you can measure it. Look for pallor seen in hematological disorders and jaundice in conditions like hepatitis. Lymphadenopathy is seen in a lot of conditions like malignancy and infections. Rashes can be of various types. We are looking for anything that may be different in the skin. You may see a salmon pink rash, as I said before, in juvenile idiopathic arthritis, or a petechial rash you can see on the right associated with hematological malignancy. You can also look for the photosensitive rash on the cheeks seen in SLE. Swollen joints can also be evident, and this may be due to arthritis or a bone tumor. Oral ulcers and alopecia can be seen in patients with SLE. Skin lesions like abscesses seen in melioidosis can be looked for, and discharging sinuses around the knee joint or shin can be examined for. Peripheral stigmata of infective endocarditis, like we talked about in a previous video, need to be looked for, like splinter hemorrhages and Janeway lesions. Features of hyperthyroidism like exophthalmos, sweating, and a goiter may be evident as well. Finish off the examination by completing the respiratory system examination to look for consolidation and pleural effusion seen with TB, and CVS examination to look for murmurs and features of infective endocarditis. Palpate the abdomen and look for hepatosplenomegaly. You can see hepatomegaly in liver tumors or sometimes hepatitis, and splenomegaly in conditions like infective endocarditis, malaria, or hematological malignancies. Look for any tenderness and palatable kidneys. This means that the kidney is enlarged so that it can be palpated in between both hands placed on the front and back of the torso. This is seen in renal tumors. Finish off with the CNS examination. Investigation forms another cornerstone of evaluation. Again, it is necessary to stress that this is a very extensive list, and we won't be carrying out this whole array of investigations, but the most likely according to the history and examination. And if still the investigations do not yield anything specific, we may go on into other investigations. We can do a chest x-ray which may show opacities or kind of masses in the lungs suggestive of TB or a lung malignancy. There can also be pleural effusions and consolidations. We can do thick and thin blood films for detecting malaria. So we create a blood film and examine it under a microscope, and we may see the parasite in the red cells, and depending on the shape and other features, we can categorize which malaria the patient has. ANA, dsDNA, and rheumatoid factor are done to diagnose connective tissue disorders, notably SLE, and a blood picture can show features of anemia, or it can show features of hematological malignancy, and a simple investigation we can do. An ultrasound abdomen can be very helpful because you can see organ enlargement by this and look for liver abscesses or features of hepatitis. You may also be able to see splenomegaly seen in infective endocarditis as well as malaria, and you can see renal tumors and an array of different features helpful in coming to a diagnosis. A thyroid profile with TSH and free T4 can help to look for hyperthyroidism. A full blood count, again, is simple and very informative. If there is an infection, you can see leukocytosis, and in conditions like TB, you can see a high lymphocyte count. In hematological malignancies, you may see very high levels of WBC counts and either high or low platelet counts. Red cell indices are important to find out if there is an anemia, and if so, what type of anemia it is. CRP is usually elevated in acute infections and can be elevated in melioidosis or atypical pneumonias. ESR is very high in conditions like tuberculosis or connective tissue disorders. A UFR might not be diagnostic of any condition, but you may be able to see hematuria associated with renal tumors, and if you do a culture and it becomes negative, but the UFR shows a lot of plus cells, it is indicative of sterile pyuria, which may be indicative of TB cystitis. You can do 3 blood cultures from 3 different sites at 3 different times to diagnose infective endocarditis. And to help with that, we can also do a 2D echo to look for vegetations on the valves. And you can take any other swabs for culture from wounds, skin abscesses, or sinuses. Even though I didn't mention it before, filariasis is also a cause for PUO, when still the enlarged limbs and lymphedema are not very evident, so we can look for microfilaria parasites in a blood film. We can do hepatitis B and C serology to look for chronic hepatitis and liver enzymes to complement that. HIV and STD screening are important, and serology for other common and not so common infections like Epstein-Barr virus or cytomegalovirus or toxoplasmosis can be done. Mycoplasma causes an atypical type of pneumonia where you see atypical symptoms and a rounded consolidation in a chest X-ray. You can confirm this by doing mycoplasma antibodies. Brucella antibodies for brucellosis can also be done. X-rays are of course helpful, and an X-ray sinus view can give you an idea if there is chronic sinusitis, which is also a cause for PUO. And X-ray joints can help give evidence for conditions like juvenile idiopathic arthritis, SLE, and bone tumors. Usually, as a last resort, we do bone marrow biopsy, and you may see features of hematological malignancies in these. Or we can do lymph node biopsy plus or minus culture to look for evidence of TB or other infections. For TB, a few things we do are TB culture, which will take around 6 weeks to see a growth. So in the meantime, we can do TB PCR, acid-fast bacilli in sputum, and MON2 test. If nothing is positive, or if history and examination findings are indicative, we can do P-ANCA and C-ANCA, which are again related to connective tissue disorders, rickettsial antibodies for typhus infection, other imaging like CT to define the anatomy and abnormalities, and fungal studies as well. Of course, this is a very limited list of the conditions causing pyrexia of unknown origin, and there are other investigations we can do according to our preliminary assessment. So, that is all about PUO from this video. But it is important to remember that PUO is a very vast subject, and the array of diseases covered in this video is limited. The diagnosis must be sought with due intuition and critical thinking. Of course, this can be tough when you are in an exam setting, but with practice you can definitely improve. Don't forget to check out the next video on juvenile idiopathic arthritis, which is essentially one cause of PUO and which is common in children. Watching both videos in succession will consolidate what you have learned here. Stay tuned! Thanks for watching!